We're going to move quickly through our next topic, which is the evaluation and management of lateral ankle sprains, which is something that we all see a lot of and really have an extreme variable way to treat this. First of all, I have no disclosures either, certainly none that I would confess to. Major question we're having today, that we're what present recommendations for athletic trainers and other allied health care professionals in the conservative treatment and prevention of ankle sprains in athletes. What are the facts and what's the fiction? So if we look at, this doesn't work now, mechanism of injury. Here's Venus Williams, plant pivot, ooh, ankle just goes. That's the classic mechanism for a lateral ankle sprain or injury to the ligaments laterally. So the incidence of lateral ankle sprains is estimated to be about 40% of all injuries. 75 to 80% of all ankle injuries are lateral ligament injuries to the anterior talar fibular ligament number 1 or the calcaneal fibular ligament number 2. The anatomy is very straightforward. You're all familiar with it, I'm sure, with the anterior talar fibular ligament being identified in the picture there, and the calcaneal fibular ligament being from the end of the fibula down to the calcaneus, which goes right across the subtalar joint. In a cadaver specimen, again, to identify the ligaments, you have the anterior talar fibular ligament up there in the center of the picture, and then down lower the calcaneal fibular ligament, and then their relationship to the Achilles tendon. And a close-up of the calcaneal fibular ligament is here. So the typical lateral ankle ligament injury, as we saw on the video with Serena Williams, is an inversion injury, which usually requires the foot to be somewhat plantar flexed at the ankle and then inverted. And these are the two ligaments in the diagram that get torn most of the time. So this is what you see as an athletic trainer when the athlete sustains a lateral ligament injury. Physical examination is difficult, right? I mean, it hurts, and they're young kids, and everything hurts, and it's really hard to determine the extent of their injury when you have someone with an ankle like this. It's hard for us in the office, too, when they come in like this, because they're on crutches, they're crying, you know, it's really hard. So to be able to do an anterior drawer test or a talar tilt test in an acute setting is virtually impossible. So it's not something that we should be trying to do on the field or right after the injury. This is something you do down the road for a chronic unstable ankle or someone who continues to have problems after an acute injury. So the question arises when you are on the field in the first line, like a military at the rush, you know, what do we do? When do we order an x-ray? When do we get concerned? Certainly in this particular photograph, you need to get an x-ray. So there's been the Ottawa ankle rules, which I'm sure you're all familiar with, which is a way to try to filter through some of these ankle injuries and determine who really needs an x-ray, i.e. who should be sent to the physician for an orthopedist for an x-ray, and who really doesn't need one. And so if we look at the ankle, you say, okay, if someone has a bony tenderness on their fibula, someone has bone tenderness on the medial malleolus, or they're unable to bear weight immediately after the injury, or when they get to the emergency room, that's probably someone who should get an x-ray. And then as far as foot tenderness goes, if you're tender over the base of the fifth metatarsal, or if you have bony tenderness over the navicular medially, and again, you're unable to bear weight on it right after the injury, then that's someone else who should also probably get an x-ray. So trying to filter out the kids who need x-rays and those that don't, if you focus on just the bony tenderness as to where they actually hurt, which is easier to do right after the injury before they swell, you'll get some good information and feedback as to who you think might need to get an x-ray. Because, you know, these kids, when they come in and they're all swollen in 2 or 3 or 4 days, I mean, everything hurts, and it's really hard to get a good exam and see, do they hurt on the bone or do they hurt next to the bone? But right away, when you see them on the field, and you're the ones who were there a lot of times, you can determine, is it sore on the bone or is it sore next to the bone? And then you get a pretty good idea as to whether they need an x-ray. Because otherwise, we're sending a lot of kids for a lot of x-rays and radiation that they really don't need. I mean, there's, we see hundreds of kids in the office here for x-rays, because as Dr. Gadd said, if they go to the orthopedist, you got to get an x-ray. And once they come in, they have their negative x-rays are a very large percentage of these ankle injuries. So in the office, if someone has been, on a chronic basis problems with their ankles, we'll get a stress test in addition to the regular ankle series, which will give us some indication as to what kind of ligament laxity they have laterally. And we use 10 degrees on this particular stress test to determine that. So the traditional treatment for someone who injures their ankle on the lateral side with their ligaments is, RICE, right? Rest, ice, elevation, and compression. And some people put P in front of that for price for prescription medication, some type of anti-inflammatory. So non-traditional treatments, you have people hold it because it hurts so much. You can put on, radishes, you can pray a lot. The one on the right with the sock of, St. Mary to bless the ankles so that you don't have further injury. Those all work to some degree. But the real question is, does the treatment lateral ligament injury make a difference? I mean, do we make a difference in getting these kids back or not, or is it just a matter of time? Recently, in one of the journals, a guy named Bryson looked at early supervised therapy versus just giving a written instruction to the kids and say, listen, we're going to randomize 540 patients and say, here, you get just written instructions and you get PT, and is there any difference? And he found at 3 months, there was no difference, which is somewhat disconcerting, and if the government find out about that, we'd do a job. So what does the literature actually support? Does ice help or does ice not help? What really helps with controlling swelling? So the NATA had a position statement that came out in 2013, basically to present recommendations for all athletic trainers and other allied healthcare professionals in the conservative management and prevention of ankle sprains in athletes. And there were a lot of athletic trainers, some with significant notoriety, listed on there as the authors. Eric, you're there. So strength of recommendation is based upon consistent good quality studies. And in the orthopedic literature, we talk about level 1, level 2, level 3, level 4. Yours is the same thing. Level A is level 1. That means you have have a good quality study, randomize the patients. Level 2 is inconsistent, and level 3 or C is usually just an opinion or a practice that people do, but not necessarily supported by strong literature results. So what about anti-inflammatories? We can't go through all of these because it's a 32-page paper, but we're going to go through a couple of the ones that are more important, just so that you can familiarize yourself with what is supported by the literature. If you want to go back and look at everything, there's that 32-page consensus statement. So non-steroidal anti-inflammatories, reducing pain, swelling, and improve short-term function. So that's supported level A in the literature, meaning that, yes, we should give them patients anti-inflammatory medication. The study that talks about that was an American Journal of Sports Medicine, 1997, so it's been out there for some time now, where Feldine was used compared to a placebo in military recruits. And they found that it decreased their pain and returned them to training sooner than if they didn't give them the medication. So Advil would work just as well. You could tell one of your kids to take some Advil on a regular basis. They wouldn't have to get a prescription medication. Functional rehab is better than immobilization in grade 1 and grade 2 lateral ligament injuries, and that's supported in level A as well, which means that if you have a grade 1 or a grade 2 ankle injury, you should start them with functional rehab as soon as they're able to do so pain-wise. So that's done with weight bearing, with proprioceptive, with balance. Those types of activities will speed their recovery back to sports as opposed to putting them on crutches for a period of time. All right. Early range of motion and passive joint mobilization is supported in the literature as well. So getting the range of motion, particularly dorsiflexion, is what helps a lot with rehabbing these kids, because when they have a swollen ankle, they can't cock their ankle to then push off. So if you can't load, if you can't cock your ankle, you can't push off. So working on dorsiflexion is extremely important to get these athletes back to play quickly. Functional rehab. There was a study at the American Journal of Sports Medicine in 1994 where they tried using air cast plus functional rehab for grade 1 and grade 2 injuries. This type of splinting or wrapping helps to keep the ankle moving, up and down as far as dorsiflexion and plantar flexion, and limits their ability to have lateral rotation. So grade 3 injuries, however, they do better with 10 days of immobilization followed by then a functional program. So if you have a patient who has a tremendous amount of swelling, has a lot of ecchymosis, and they're tender on both their anterior talar fibular ligament, their calcaneal fib, and even posteriorly on the posterior talar fib, then a period of immobilization or on crutches for 10 days or so has been shown to be effective as an initial treatment for the more severe ankle injury. The question arises about lace-up bracing versus taping, and what is more effective in reducing recurrence. The studies have shown that they're equally effective, but that after someone who has had an injury to their lateral ligaments, you should either tape them or brace them to decrease their risk of recurrence. And that is supported in the literature, okay? However, what isn't shown in the literature is that lace-up bracing or taping prevents initial injuries. All right, so it does help with recurrent injuries, but it doesn't decrease the rate of initial injuries. Balance training is very good to prevent re-injury. Using these BOSA balls help with proprioception and to balance the weight through the ankle. Very important for the sports and also preventing re-injury. Some of the ones we use on a regular basis are less supported by the literature, mostly because it's hard to get a randomized study as to who you're going to use ice on and who you're not going to use ice on. So they are supported by a lower level of evidence in the literature. Doesn't mean that we don't use them, but cryotherapy, compression wraps, and elevation are all things we just do on a regular basis to try and decrease the swelling and help the joint start to work with range of motion. Other modalities that have been suggested, such as E-stim, ultrasound, and cryo cuffs, currently there's insufficient data to recommend these treatments. So the person who then goes on to chronic ankle instability, I'm going to skip this video because we don't have time. We'll have an example of their x-ray in the office shows chronic lateral laxity with greater than 10 degrees on their talar tilt. There we go. So this is a cadaver specimen showing the ankle range of motion with the ligaments intact. And then here's a dissection. The peroneal tendon is at the retractor, and the scissors are cutting the calcaneal fibular ligament. And you can see when that's cut, and then you start to invert the ankle, you can see the joint, the subtalar joint opening up, and then also the talus and the distal tibia joint will open up as well when we cut this other ligament. We'll demonstrate that in a second. There you go. So that's what's demonstrated on the stress x-ray when the ligaments are no longer tight enough to prevent this type of motion. So sensorimotor training is very important in these chronic ankle instability patients. The wobble board and neuromuscular control to reduce the risk of re-injury. If patients don't make progress, certainly there is a role for surgery, but surgery for the chronic ankle instability patient is certainly not something we promote in the patients because of a number of things. The most common one is that frequently there was a review done of 180 surgeries for chronic instability, and 64% had an associated condition at the time. Either they had a split tear of their peroneal tendon, they had an issue with their os trigonum, they had loose bodies, they had an OCD, they had some other thing going on. So I think it's always good to evaluate the patient who has chronic instability complaints in their ankle, but the workup needs to be complete so that you don't miss something and just figure it's their ligaments. Because the majority of patients with lateral ankle injuries, you see them all, they do get better with the appropriate treatment and with bracing. So there's a variety of surgical procedures that have, we won't go through them all. There's anatomic repair, there's reconstructions. Primary ligament repair is called a Brostrom, which is schematically described or shown in the picture there. There's a modified Brostrom. The reason we stay away a lot from these ankle surgical procedures for ligaments is because you look at the time to return for the athlete. Just for running or jogging, it's between 10 and 14 weeks to jog. So you're taking out of athletic competitions to jog for 3 months, and probably until they play in their sport, somewhere between 5 to 6 months. So for a high school athlete, taking them out for 6 months to do a procedure like this is a long period of time. So this is just a slide looking at one of the ankle reconstructions that used to be popular. So in summary, the management recommendations that we have are basically we should use nonsteroidal anti-inflammatory medication. Advil would be sufficient. For grade 1 and grade 2 ligament injuries, functional rehab to start as soon as the patient can tolerate the weight-bearing status. Grade 3 sprains are the more severe ones. We should immobilize for approximately 10 days before starting the program. Balance and neuromuscular control program is very important. Lace-up bracing or taping for return to play is highly recommended. The Ottawa ankle rules for x-ray referral, we should always check for bony tenderness. And then ice, compression, elevation, ultrasound, stim, we should use as we need to, but not necessarily use that as the hallmark for treatment. And then there's just one thing we need to remember is that no matter what you do, you can't help everyone. And some people in high heels are trying to lift weights and their ankle's going to go. And you can't help them.